just to give an overview of my presentation, I'll begin by talking about the background of the study. I'll move into a conversation about the methods I used to collect my data and how I analyzed it, and then give a pretty detailed description of my results, along with some discussion, and then we'll end the conclusion. You can feel free to ask me questions as I go along, but if you want to wait until the end, there's 15 minutes still, so you can ask at the end as well. So to begin with the background, in 2011, the Duke University Moore University Comparative Health Twinning Program was launched, and this was led and developed by DGHI faculty Dr. Wendy O'Mara, who some of you may know is based in Eldoret, Kenya. And this program pairs an MPH student from Moore University in Eldoret with a Master of Science student here from Duke. So this past year, I was fortunate enough to be a participant in this program and was partnered with Sharina Depot, who is right here, to investigate the health of United Methodist Church clergy in Western Kenya. So Sharina and I spent 6 weeks in Kenya, and then she came to Durham and we spent 6 weeks here analyzing our data. And these are just pictures of us in both places. This is in North Carolina, obviously, and that's in Kenya. Our study is part of a larger ongoing study here at Duke, the Duke Clergy Health Initiative, and this is directed by my thesis mentor, Raging Proshel-Bell, and it's been looking at the health of United Methodist Church clergy here in North Carolina since 2007 is when they got funded. And over the past 4 years, they've done 13 focus group discussions, and 4 waves of quantitative surveys have been administered. And their surveys have asked questions of diagnosis, of ever having been diagnosed with diabetes, obesity, arthritis, asthma, and different medical conditions like that. And this is important to keep in mind when we talk about why the study of clergy is important, because the rates of disease for clergy in these areas were much higher than North Carolinians of the same age range and sex for the diagnosis of diabetes, arthritis, asthma, blood pressure, and obesity. So for obesity, they were up to 40% higher than North Carolinians of the same age range and sex, which is fairly significant. Our study was also set up to be a comparative analysis between the United Methodist Church clergy in Kenya and the ones here in North Carolina, and that will also be relevant as I talk to you about the formation of our instruments and our code book, because we tried to do it in a way that it could be compared in the future. From the qualitative data, we found, or they found, that the pastors define health holistically as mind, body, and spirit. This will also be relevant when we talk about what I found for the Kenya United Methodist Church. So, based on the results, these 2 results, and obviously many more results that I will talk about for the Duke Clergy Health Initiative, they began this Spirited Life intervention, which is this multi-year health and wellness program that has a spiritual component, but they also offer nutrition services, a dietitian, and other physical and dietary components to this intervention. And they started that last year, so they're in the 2nd year of this intervention for United Methodist Church pastors here in North Carolina. So just to tell you a little bit about the United Methodist Church in Kenya, it began in 1993 and split into 4 provincial regions, and then those regions were further split into 6 districts that are led by either an associate district superintendent or a district superintendent who administers or coordinates the districts. This is the Central Nyanza District Headquarter Office that Shereen and I visited in Migori, and the district superintendent there told us that there were over 100 male and female pastors living and serving in the United Methodist Church in Kenya. So to be even more specific, this is a map of Kenya bordered by Uganda, Ethiopia, Somalia, and Tanzania. This is the western area, the area kind of between the Rift Valley and Lake Victoria. And then if we focus on this region, here are the provinces and districts. The provinces are the rectangles and the districts are the circles. And Shereen and I were here in the Nyanza province and traveled throughout the blue circle above and below to collect our data. So why address clergy health? One of the main reasons I talked about was this worse physical health for clergy compared to the general population. We also know that clergy have a unique role in society. They navigate social and spiritual waters. They point people to God. They give advice for their parishioners. They teach people. Often acting as caregivers and counselors, they tend to neglect their own health to take care of the health of other people. and they have been found to have higher symptoms of stress, depression, and burnout. However, outside the US, the UK, and Canada, that very little has been documented on the health of clergy. We do know that religion plays an important role in the lives of people around the world, so it's an important subject to study with religion being so important, and we want to know how clergy are affected and how their health is. So our studies sought to obtain information regarding clergy health in Western Kenya in order to shape future interventions and study. Like I said before, the Spirited Life intervention was developed as a result of the studies conducted here, and we wanted to get exploratory information to see if an intervention like that would be helpful in another setting. The specific objectives that we used were, one, to investigate how clergy conceptualize health in Western Kenya. The second is to understand how religious beliefs may affect health-seeking behaviors, and third was to determine how indigenous cultural traditions affect health-seeking behavior among United Methodist Church clergy in Western Kenya. So we kind of looked to answer these aims and objectives with this primary question: what are the health-related beliefs and contexts for United Methodist Church clergy in Western Kenya? And you can see the secondary questions there. They align with the objectives, so I won't read them, but these were the secondary questions. So now to methods. There we go. So Shireen and I hired a community liaison to help recruit our participants, and this person was the United Methodist District Superintendent for Central Nyanza District, and he recruited all of the pastors in our study. So we had this big meet and greet one day, and over 50 pastors came, and we got to meet them and kind of become familiar with them. We also went to church services, shared meals at pastors' homes, went to different health clinic meetings, and tried to become members of the community and did a little bit of participant observation. In addition, we conducted 9 in-depth oral interviews and 4 focus group discussions with a total of 49 pastors. This table shows the breakdown by region. So we collected data in 3 main cities: Migori, Mahuru Bay, and Kuroka, and this is the number of participants. I highlighted that we had 3 female pastors and 2 associate district superintendents because we were trying to get a mix of local pastors and district superintendents as well as females. So out of the 49 participants, 4 of them were women. One associate district superintendent was female. So this is just a snapshot in the field. This is our first focus group discussion in Migori that Shireen conducted outside under the tree. It was hard. We audio recorded all of our focus group discussions and interviews, and I remember there were a lot of cows during moving on this one, and so the recording was hard to do. But this is an interview I conducted in Mahuru Bay with a pastor. So I talked about this a little bit previously, but we use the Duke Clergy Health Initiative focus group discussion guide as a template for the formation of our questions. We thought this would be useful for future comparative analyses. And I worked with Shireen and Eunice, who is a religion professor at Moy University and my in-country mentor there. So she has a lot of experience, obviously, in religion, to make the questions culturally relevant. So we kept a few of the questions exactly the same, altered some of them, and then added additional questions. And the questions that we added were mainly about religious beliefs and indigenous cultural traditions that would not be relevant here. We then used this focus group discussion guide as a template for our in-depth oral interview guide. And the 4 of us added a bunch of questions and then narrowed them down. And when Shireen and when I arrived in Eldoret, we pre-tested the oral interview guide with 2 pastors in Eldoret, and they said only minor changes were needed, so that's what we kept. And then Shireen translated and back-translated from English to Swahili, and then a local pastor checked the translation to make sure it was okay. So this is just an example of our questions. It ranged from definitions of health to what programs are available to clergy, what cultural beliefs and religious beliefs affect health, how do pastors attend to their health, questions like that. So to move on to data analysis, like I said, we audio recorded all of our transcriptions, and we hired a transcriptionist from Moy University to transcribe our data for us, and then we entered all of those into NVivo 10, which is a qualitative software package. We used a combination of grounded theory analysis and interpretive phenomenological analysis, which I will call IPA because it is hard to say from now on. And we use that to analyze our data. We also use the original Duke Clergy Health Initiative codebook as a template, again with the idea that we will compare in the future. We tossed out a lot of those codes and then created new ones based on the data, and we used grounded theory for that, which I'll get into in the next slide. And we coded each transcript for themes, and then Sharina and I double-coded a few of the transcripts just to make sure we were on the same page. So grounded theory analysis was invented by two sociologists, Glauser and Strauss, and it goes beyond mere data description to describe the data in a way that is theory generating. So it generates a theory that explains a pattern of behavior, way of thinking, and it does this by studying the lived experiences of participants. Two main hallmarks of grounded theory are line-by-line coding and memo writing, and Sharina and I used both of these. Line-by-line coding was the way that we generated our data-driven codes. So we went through our first focus group discussion, which was like 60 pages, and went through line by line and created these gerund-based codes. For example, defining health, believing God saves, seeing illness as weakness were some of our codes. And those, the reason, I guess, that grounded theory decided to do it this way is these action type-based words help you interact with the data in a creative way as opposed to just writing kind of things that you see. We also engaged in memo writing, which is a form of analysis that begins at the beginning. So instead of waiting until the very end to code all of your data and then try to create relationships in the text, if you start memo writing as soon as you begin analysis, you can create those relationships early on. So we did that. We also used IPA. It, like grounded theory, doesn't seek to answer a hypothesis, but is explains how participants make sense of the world around them. So in this case, it was how do United Methodist Church clergy make sense of their health in the Western Kenyan context. And how we used IPA was in our code generating, or I'm sorry, in our theme generating. So we grouped all these codes into categories and then generated themes the way that IPA traditionally does. So yeah, that's what we used. Now I'm going to move into the results. Does anyone have questions before I? So these are the 5 main domains that I came up with. I should have maybe said this before. I focused on conceptualization of health, and Shireen focused on the barriers and facilitators to health. So that barriers were very, very pervasive in the data. And I wish I could have written about them in my paper, but for her thesis purposes, we weren't allowed to have any overlap. So if I'm not mentioning them, that's why, but they were definitely there. There were a lot of barriers to health-seeking behaviors, but I had to kind of stay away from that aspect. So all of the domains I came up with were on conceptualization of health. The first one was defining health, the second, believing God saves, the third, seeing illness as weakness, the fourth, intersecting cultural beliefs, and the fifth was seeking medical attention. And this fifth domain actually was our outcome of interest. So you can see how all the first 4 domains kind of influence or affect this last domain. So I'll talk about how definitions of health affect seeking medical attention, how believing God saves does that, etc. And then on the bottom I have numbers, and that's the number of times each domain was coded in the data. So you can see that these ideas were very pervasive. They weren't just coded once or twice, but over 150 times for each of them. And these numbers were derived by the themes that were underneath each of these and the codes that were under each of these. I added those together and kind of came up with those numbers. So underneath defining health was like 6 codes, and then I tallied those and came up with that number. It was a really big table and it wouldn't fit on the slide, so This is just a summary of the domains and some of the themes, and as I go through the specific results, I'll be talking about 2 themes per domain. So the first domain is defining health. A male pastor said health touches on all those diverse aspects of human life, the physical, the spiritual, and the social. So before I get into their definitions of health, just to give you a broad idea of how health is generally defined, there's 4 common ways. There's many more than that, obviously, but the 2 that I'm going to hit on today are the World Health Organization model, which is the holistic view of health, and the environmental model. So the first, the medical model, is this kind of traditional way that health is just the absence of disease. And then over time, the World Health Organization came up with this idea that health is more than just the absence of disease, but a state of being complete in physical, mental, and social ways. The wellness model, which I won't really talk about, kind of prioritizes health promotion and progress toward higher functioning. And then the environmental model looks at how you adapt to your physical and social environments and how that kind of affects your health. So the first theme that arose under defining health was that health is holistic. As I said previously, the United Methodist Church pastors here in North Carolina define health the same way. So it wasn't entirely surprising that these pastors define health in this way. In addition, Africans don't really compartmentalize religion and health. So they see the human being as this holistic unit made up of mind, body, and spirit. And that's true for more than just clergy, but that's true for Kenyans, East Africans, Africans in general. Obviously, you can't generalize everywhere, but that's pretty true, this idea of a harmonious being. Participants repeatedly stated that health is not just the absence of physical disease, but the presence of mental and spiritual well-being. So that idea came up in every focus group discussion that we conducted. The next idea kind of touches on the environmental model, which I just mentioned, but participants stated that a clean and sanitary environment is necessary for good health, which I thought was really interesting. Specifically, a pastor said that your living conditions must be good, your living environment must be clean, and at all times be a person that loves cleanliness. We should see that our health is clean. So you can just see from that pastor that health is kind of linked with a clean environment. And I know some of us in this room have been to Uhuru Bay, and if you just think of places in East Africa in general, the level of sanitation in some of these areas might not be the same as they are here. And so for them, this was really important. The concept of having clean water and clean food and good sanitation was pivotal for them to have good health, and that was not always the case. And I think that's why it was this reoccurring idea. And it was flip-flop too. So your environment must be good for your health to be good, in the same way if you're living in bad conditions, then your health will be bad. And a female associate DS said that. So this idea of the environmental model, that your health is kind of influenced by your social and physical surroundings, was true for some of these pastors in this area. So moving on to the next domain, believing God saves. I thought this quote was really powerful. Their conscious decisions was they always believe that their God is able, to an extent that even if somebody is almost dying, he still believes God saves. And I'll touch on that in a second when we talk about the themes. The first theme is that God heals every ailment. So pastors said multiple times, every sickness will come, but the solution is to seek God in prayer and trust that he will heal. And that's what this first male pastor said. He takes up his faith by reading and studying God's word, and he always finds himself getting healed, recovered, just because his faith has kept him. This pastor says that the Bible states that Christ has already healed us, and he quotes a verse in Isaiah 53 that says, "By his stripes I am healed." So they often reference Bible verses for why they trust God for physical healing. The next theme that came up, which was really interesting, is that this trust in God's healing might be because of circumstances. So Nyanza province, where Shireen and I were, has the highest rates of malaria and HIV in Kenya. And additionally, the United Methodist Church pastors there do not have any salaries. They're relying on the tithes and offerings from the members of their congregation. Because of various reasons, this region specifically is very impoverished. So the salaries that or the offerings that they're relying on are pretty small. I would say that most of the pastors are living below the extreme poverty line, which is $1.25 US dollars per day. And obviously, not everyone disclosed their salaries to me, but many of the pastors kept saying, we're living in extreme poverty, we're living below the poverty line. And that's one of the barriers to health. Like I said, Shireen is writing on that part, so I didn't touch on it. But they stated that trusting God for healing could be the result of poverty or other impediments to seeking care. One of the pastors said it's because of poverty that his faith has been built. So this idea of we don't have the money or the resources to seek medical attention, so we're not forced to trust God for healing, but kind of, like they don't have any other real option. A female associate DS said she's sometimes walking to the medical clinic and reminds herself that it's 4,000 to 5,000 Kenyan shillings, which is like 45 to 60 US dollars, and that there's going to be long lines. So she's like, well, I'm just going to trust God instead, and I'm not going to go. Like I said, if they're making $1.25 a day, that is like 2 months of their salary. That isn't even guaranteed since they're relying on tithes and offerings. So it's a major barrier, and it could help explain this desire to trust God because of their circumstances. The third domain is seeing illness as weakness. And it's this idea of hiding under the scripture so that the flock can continue to believe in the word of God. So something that came up a lot is that pastors often will keep their illness to themselves, and they're worried that if they disclose their illness to their congregants, that they will lose their faith in God, the congregants will. One of the pastors said, we don't want to disclose ourselves to the flock. We want to hide under the scripture, but actually we also as pastors need to seek for medical help, but we fear going there because our flock will lose their faith in the word of God, which I just thought was interesting. Personally, just wondering, who are they choosing to put their faith in? Are they putting their faith in God or in the pastor? And why is the pastor putting this kind of pressure on himself to never be sick so that the congregation would keep their faith? I'm not sure. And I would love, and I'll talk about this in future directions, but I would love to interview or do focus groups with members of the congregation just to see if these fears are warranted or if it's something that the pastor kind of puts on himself. This other pastor said many of the pastors have health problems. Some of us have eye problems, we have ulcers, we have all these things, but no one in the congregation knows because we don't want them to lose faith. Another thing with fear that came up is fear of going to the medical center or the pharmacy because it will seem like the pastor is without faith or that he's immoral. And I don't know how many of you were there Monday night at the Global Health Showcase, but I talked about this just for a minute, that the idea that HIV is a moral disease was very pervasive, so many of the pastors won't go to get tested for HIV because they don't want to be seen by the community as they're immoral, or that they're a hypocrite. So this pastor said, some pastors fear going to the pharmacy to buy drugs because if the community sees a pastor going to buy drugs, it means that you're a faithless person. You're supposed to be bringing us healing, so you cannot preach of water and drink wine, which is this idea that the pastor will be seen as a hypocrite if he is found to be sick or seeking medical attention when he's supposed to be having this immense faith. This pastor talks about going to get an HIV test. You realize some pastors are HIV positive, and a pastor will fear going for that test. That if they find out that pastor so-and-so and I'm positive, how will I go preach? This idea that the congregation will see them as immoral and it will ruin their standing in the community. They're found to be positive with the disease. So oftentimes they just won't go and get tested. Or they'll go and get tested and know that they're positive, but they're afraid to go to the pharmacy to get drugs. So it's kind of a test. fourth domain, intersecting cultural beliefs in health. This quote is about how a long time ago there were not biomedical practitioners, so the pastors in the community had to rely on cultural doctors, witch doctors, sorcerers, whatever, for healing, because they didn't have medical doctors. So they still utilize traditional medicine today, the clergy do. They recognize that some diseases are due to evil spirits, and that only a cultural healer or a magician would be able to cure those diseases. So a pastor says, we also seek the Spirit's intervention, not the Spirit of God, but traditional spirits in our situation of health. And they talked about this repeatedly, that if any disease had a spiritual element to it, not a Christian spiritual element, but a traditional spiritual element, that they would never go to a medical doctor because they wouldn't be able to fix it. That's just another quote. We believe that there are these things that one should not go to the hospital, but be treated at home. One should use herbal medicine because they believe that the spirit heals. So some of the clergy, and I imagine other people in the community, believe that if you do go to a doctor and you have a child who is sick with the evil eye, that child would die immediately because the doctor would, whatever the doctor did would kind of counteract the evil eye in a bad way. So there are a lot of these kind of magical spiritual ideas in the people that I talk to. In addition, kind of taking a different idea on cultural beliefs, the traditional male role is still held, and we know just from the literature that in general men are less likely to seek medical attention, and this is not an exception in Kenya. Most of the pastors, like I said, only 4 of the 49 were women, so the majority were men, and they said that they're not used to getting advice, they're not used to seeking advice, and they specify that they don't seek out medical advice. And so you can just imagine that in addition to these other kind of impediments to seeking care, not wanting to seek out medical attention in general is another one. That this traditional idea of a man not wanting to ask for directions or not wanting to admit that he's sick or whatever it is still very true. The last domain, so this is seeking medical attention. Just to remind you, this is also the outcome of interest. I know that was like 20 years ago when I said that, but now you can remember. So those other domains kind of influence how and when the clergy will seek medical attention. This quote is about a pastor told me that from 1969 until now, he's never gone to the medical doctor. If he has the flu, the best thing he can do is ask his wife to give him hot water, and he'll pray and ask God to help him, and then he will be healed. So this has a lot of overlap into the believing God heals domain, but there's 2 main ways that the pastors saw seeking medical attention. They either saw that God alone heals and they chose not to seek medical attention, or they saw that God heals but seeking medical attention is still okay. So this is the first one, that God is totally enough for physical healing. This, at the bottom, this male pastor says, there is no pastor who would want to go to the hospital because they've already been saved or healed by God. The male pastor at the beginning says, he prays to God and he helps me. Sometimes he feels himself getting sick, but as soon as he prays, he finds himself better. And I didn't include some of these quotes because they were very long and the context wasn't exactly right for a presentation, but many of the pastors said there is no way they would seek medical attention, and that people operate at different levels of faith, and for people that are operating at the highest level of faith, like they are as pastors, their faith will heal them, and the only way that they would go see medical attention is if they're dying and people force them to go, like they're being carried, or that's the only reason. They said pastors have died on the pulpit because they refuse to seek medical attention, just because they're seen as not having faith if they do that in their eyes. I wish I knew if they were actually seen that way, but I don't. So this is the other side of that coin, I guess, that modern medicine can be useful. So before I get into these quotes, there was this idea among the male clergy that it was totally fine for their wives and children to seek medical attention, which I thought was interesting since, I guess because they're operating at a different level of faith, which is what they said, that they were kind of held to this higher standard of faith because they were pastors, but it was totally fine and even encouraged for their wives and their kids to go get vaccinated, for their wives to go seek antenatal care, whatever it was. And because we only had a few female participants in this study, I couldn't get a good read on if that was just if the female clergy would feel the same way. This female pastor did say, if you or your child is sick, pray first and then go to the hospital. A male pastor said that we believe that Christ heals us, but we also know that there's other things in the world that can give you diseases, so you can go to the hospital and God can use a doctor too. Okay, so the conclusions I reached. Well, first, limitations. So one of the limitations, obviously, is that only qualitative methods were used. So like I said at the beginning, the Duke Clergy Health Initiative was able to conduct these 4 waves of quantitative surveys, and they were able to find medical histories and diagnoses of pastors. We were obviously unable to do that, so we don't really know the burden of disease among the clergy in this area, and that would be really interesting to find out, but was a limitation of this study. There was also kind of initially when we got there, this misunderstanding of international aid and research. And I'm not sure what the district superintendent told the pastors when he was recruiting them, but when I got there, he told them that there was this team coming from the United States, which was just me and Shireen, who was Kenyan. So they expected this group of people from Duke coming with their medical equipment and healing them. And I am not a doctor, nor did I have any medical equipment to share. So there was just kind of this confusion in the beginning of why are you here to help us? How are you helping us by asking us questions? And so I'm not sure if that influenced any of their responses. I tried to clear it up as much as I could, and Shireen did too, to just say, we're here to learn from you, we're not here bringing you anything. We gave them pens in compensation for their time, but we didn't have any medical advice to give them. And I even had 2 pastors come up to me after a focus group with their medical bills and asked if I could pay them. And he's like, well, I don't understand, why else are you here? You're not here to pay my medical bills. So it was just hard. And like I said, this specific region in Kenya has been hit really hard by HIV and malaria. And there are tons of NGOs working there, and some are doing a really good job, some are doing less than a good job in kind of distributing resources or whatever it is. So there was just this perception that I'm from the U.S., I'm coming with goods or something. So we don't know how much that actually influenced our data or the answers. I'd like to think it didn't at all, but a third limitation was how we formed the focus group discussions. We formed them based on region, which I thought would be good because it's people from the same tribe and background. At the same time, it could be a limitation because they might not be as comfortable sharing in front of people that know them or know their families. So I didn't, and I don't think Shireen personally saw that to be the case. The pastors are very open and talking to us about their health, and they were actually thrilled that we were there in addition to the medical supply thing. They were just really encouraged that people were interested in them specifically and about their health, and they were really interested in talking to us. So I don't know if that hindered it at all, but I just listed it as a limitation because it could have. Lastly, the district superintendent was kind of lingering during the focus group discussions. He wasn't supposed to be a part of them at all because the pastors were a little bit intimidated by him, and we didn't want them to be influenced, I guess. But some of the focus group discussions were outside, and he would kind of walk by, and when he did, everyone started whispering because they didn't want him to hear what they were saying. So that might have affected kind of those responses when he was close by. I'm not sure how much it affected it overall, but it definitely, he was like very close when I was conducting an interview, and the guy was whispering the entire time of my interview, and I probably should have asked the GS to leave, but it was a weird dynamic, so I didn't really have that power. Okay. Finally, summary points. So, in general, Africans do not compartmentalize religion and health, but integrate these to form a harmonious, united whole. Clergy define health holistically, emphasizing mind, body, and spirit. Indigenous cultural tradition is still very much alive in this region in Kenya and influences when and how clergy seek medical attention. And that believing God heals is a common theme among clergy, and it affects whether or not they choose to seek medical attention. Okay. So the very pending next step is for our team to write this comparative analysis. We're going to wait until Shireen is done defending her thesis in the spring and then start that analysis. We'd like to do focus group discussion and interviews with clergy, spouses, and members of the community, like I touched on before. It would be also great to conduct quantitative study, statistic study on the burden of disease there. And then I've been talking to a person here at the Duke Clergy Health Initiative about a local training center in Kenya for United Methodist clergy. This has nothing to do with health, but they talk a lot about not having formal training. And there is a center similar in Ghana for United Methodist clergy, so we're going to see if we can replicate that a little bit and have a center there for them to kind of get some more advanced training. And here are my acknowledgements. So Regine is my chair, Eunice Kamara, who's from Moy University in Kenya, and Sarah Benjamin Nealon, who's here at DGHI. My research partner, Shireen, my unofficial committee is what I call them, my mom, who read my paper and gave me a lot of credit, and Wendy O'Mara, Sarah Martin, and Lisa McKean, who are DGHI staff and faculty. The Duke Global Health Institute obviously provided funding and support. The Duke Divinity School, which is where the Clergy Health Initiative is housed. The East African United Methodist Annual Conference, which is what the group in Western Kenya falls under. And the clergy, obviously, who participated in my study. And then all of you guys for coming, my family and friends that are here, thank you very much. Yay. So this is just Shireen and I with a focus group. So if you have questions, you can ask me now, or you can email them to me later.